We have learned a lot about the biology of myeloma, and we certainly understand that it is not just one disease. Patients can have very different outcomes based on some of the initial characteristics that we see with this disease. And this has led to the whole concept of risk stratification and risk adapted therapy. Now, these concepts are not new to cancer, but I think we have the tools to apply that to myeloma now more so than what we had in the past. There have been a variety of different risk stratification systems that have been developed, but I think they all boil down to few critical elements. The most important driver of outcome in myeloma is the genetic abnormalities that we see in this disease. So by doing FISH-based testing, we can identify that the majority of the patients with myeloma have some abnormalities, and about a quarter of these patients have abnormalities which we characterize as high-risk myeloma, and they typically tend to be deletion 17p, translocation 414, 14, 16, patients with high levels of serum LDH, and also the high ISS staging system. Now, this all have been compiled into a single staging system called the Revised International Staging System, which can be very beneficial in terms of trying to decide or trying to explain to the patient what outcome is anticipated with their particular myeloma. It also helps us decide what kind of treatments to give in patients with particular abnormalities, especially the high risk abnormalities like the 17p deletion and the 414. We know that a proteasome inhibitor based approach certainly seems to improve their outcome. There is also data suggesting that maybe doing tandem autologous stem cell transplantation may be beneficial to those patients. So the risk stratification systems we have now informs the patient about the prognosis, but also helps the physicians choose therapy. The frontline therapy for patients with myeloma depends a lot on the availability of the drugs. So the choice might be different in the United States versus Europe versus some of the Asia Pacific. Let's take the situation in the US, for example. The most commonly used regimen in the newly diagnosed patient is currently a bortezomib, lenalidomide, dexamethasone. Now, we know that a combination of proteasome inhibitor and an immunomodulatory drug is the optimal combination based on phase 3 data showing that there's improved survival, overall survival, when you use the triplet combination compared to just using lenalidomide and dexamethasone. Now, how further can we adapt the therapy depends on the particular characteristics that the patients present with. Now, if somebody is older, they may not be able to tolerate a triplet, and we may decide to use just 2 drugs. We could also elect to use triplet, but use them at lower doses in the older patients. Now, patients who present with renal insufficiency, we would select drugs which are not affected by the renal failure. In such a patient, we might use a combination of bortezomib, cyclophosphamide, and dexamethasone instead of bortezomib, lenalidomide, dexamethasone. Again, focusing on minimizing the toxicity, but at the same time maximizing the efficacy. Patients with myeloma live a lot longer than what they used to do a decade ago. And a lot of it is because we have a lot of different treatments available and the combinations that keep the disease under control for longer periods of time. So what we use for treatment of relapse disease is becoming more and more important, because we want to and are able to keep the disease under control for long periods of time. Now, that also in turn will have an influence on what we select for the initial treatment. So we want to be selecting medications or combinations that will have least impact on what the subsequent treatment will do for the patient, both in terms of efficacy and toxicity. So we want to go with regimens in the beginning that will have least likelihood of creating permanent toxicities, which then might decrease the ability to use a particular class of drug in the subsequent lines of therapy. So I think what we have today is patients in the first relapse have better outcomes than what patients at the time of diagnosis had 10 years ago. So it's a very critical point in terms of what we use for the initial therapy. It is also important how we manage the toxicity from the initial therapy. So if somebody develops peripheral neuropathy that is irreversible, that can have an impact on what we may be able to use subsequently. Similarly, using treatments which could have a cumulative effect on the bone marrow and can lead to low blood counts can also impact what we may be able to use subsequently. So these factors need to be taken into account both in terms of selection but also in terms of adapting the doses as we go along with the treatment.